please feel free to turn your camera off, but otherwise, it's always nice to see your smiling faces. So, good evening. I'm Nigel Denning. I'm one of the directors of the Integrative Attachment Therapy Institute. I'm a counselling psychologist, and I've been involved in this work for quite a few years now. I was initially introduced to it through the work of Daniel P. Brown, and through Dan, I met David. You might want to introduce yourself, David.
Hello, everybody, and welcome from all over the world. Many different time zones.
The United Kingdom.
Yeah, and yes, I'm thrilled to be here and part of what we're offering to you, and part of what we've been developing over quite a few years now. Working closely with Nigel and Traill, we've been refining the work that was initially conceived of and proposed by Daniel Brown, as Nigel mentioned, who was a mentor of ours, and I worked very closely with for quite a few years. And we can go in a little more to the backstory of that as you'd like, but that culminated in the publication in 2000 and, whoops, I don't know if you can see this. Well, I guess not. Let's see. It doesn't work. Okay. Anyway, it culminated in the publication in 2016 of a book called Attachment Disturbances in Adults, Treatment for Comprehensive Repair. And that 752-page volume has had quite an impact in the field, it seems. It won a prize from the writing prize from the International Society for the Study of Trauma and Dissociation. And we've been getting requests from people, again, all over the world for opportunities to learn this material, which we have refined into Integrative Attachment Therapy, which is...
Thanks, David.
Right.
Might introduce Traill to the group.
Great.
Yeah, hi everybody. My name's Traill. I'm an associate professor of psychotherapy here in Australia, and I've been working with Nigel and Denning and David Elliott here for many years, developing this work, and really excited to be here with you all.
We've got Canada, East Gippsland here in Victoria, and Coburg just up the road. Hello, hey Dash, how you doing? Hey, Patrick in East Gippsland, Jennifer in Toronto. So it truly is an international program that we're building here and developing. So what we'll do this evening is we'll just have a bit of a conversation about the model. We'll talk about the upcoming training, and the structure of our training, and just give you a bit of an overview, and then leave plenty of time at the end for questions and answers. You know, we really want this to be just really informative for you, and to give you as much information as we can about what we believe is an incredibly strong practice model. As David was saying, this work, what you were working for something like 10 years in your supervision group in developing this before the publication of the 2016 text, weren't you, David? Up there in Boston?
Yes. Yeah, we had a study group that was designed to actually add to what or remedy what we consider to be limitations in the field of treatment for adult attachment insecurity. There had been so much, there had been growing interest over quite a few years, and within the psychotherapy community, lots of approaches, or a variety of approaches to treating adult attachment insecurity. But what we had learned and what we had experienced considered that there was opportunity for making the treatment more effective and more efficient. So Dan drew from areas of his expertise, and he tapped initially 11, or actually 10 other clinicians to come together twice a month and explore this topic, and to develop in a practical, both theoretical and practical sense, material that we could both apply in our own practices and, if effective, which we were finding it tremendously so, would then be able to benefit the practices of more and more clinicians who are interested in helping people with insecurity. So that's what we did over, it was actually, yeah, it was 8 years that led to the publication of the book. And we've been teaching it for quite a few years. Dan went to Melbourne and taught Nigel and Traill a lot of this material, and they've subsequently been bringing it more fully to Australia and beyond. And we've been working together to, again, refine the model. This model is a living, growing system. It's not a stale theoretical set of constructs. So we've been taking feedback from our own clinical work and from clinicians that have been practicing this as well, and refining the model so that it becomes even more effective and even more efficient in treatment.
Thanks, David. Next slide, please. So the model that David's describing is what we've described as a meta model, and the three pillars is the term that Dan and David developed initially in their primary text. What we did in building the current online and in-person training is actually invert the pillars. So initially, in the core text, pillar one was the ideal parent figure protocol that we'll touch on as we enter the conversation tonight. And then collaboration and metacognitive capacity were pillars 2 and 3. And in looking at the model, what we realised was that this is a meta model for any good targeted therapy. So collaborative behaviour, collaborative relational abilities becomes pillar 1. Metacognition and mentalizing to attain a metacognitive view becomes pillar 2. And these are two broad categories that apply to any good therapy, really. Building a strong relationship, building a trusting relationship, and helping people to create a better view or a different view of their position in the world. And then the treatment itself, which is the reframing the internal working model. Yeah, Traill, you might want to say a little bit about the three pillars orientation.
Yeah, well, I mean, it's a very elegant account, and of course, one of the challenges is elegance and simplicity sometimes get mistaken. But really, what you have in the three pillars is a unification of specific and non-specific treatment factors put together in a really simple and easily digestible format. As Nigel was saying, collaborative and relational abilities obviously make up a huge component of change in any form of therapy, but one of the important developments in recent psychotherapy research and outcomes is the role of metacognitive ability. Metacognition is inculcated in all psychiatric disorders negatively. And so the development of this reflective function, we might say, or mentalization, or whatever language you'd like to use to describe it, it is in fact the most common of common factors in all therapy. All therapy seeks to improve metacognitive or reflective abilities. And so these first pillars then set up the specific model, or the specific dimension of the model, which is the ideal parent figure protocol, which is really a very interesting and again, it can seem a little bit simple to people, but when you get into the nuance of it, there's so much complexity, where what we're trying to do is target and modulate the attachment system through the use of stimulating affect and imagination. So really, really elegant system. You know, I know certainly for me, with a more psychodynamic background, a lot of the attachment treatment was very hit and miss. And then, coming across this work, just being astounded at how powerfully and also how quickly it was able to create real change in people with attachment disruption. So, we spent many years trying to develop it based, I think I'd be right to say for all of us, based on our experience of just how wonderful the real world results have been.
Yeah, thanks, Traill. And those real world results have come from now, there's hundreds of therapists now around the world, aren't there, David, that have been taught, if not thousands, taught the model, practiced the model in various settings. And so part of this project is really to kind of bring this together in a very focused and part of our passion here is to really ensure that we're building a community where we're able to keep very, very clear on the clinical direction and really make sure that we're supporting people to do this work really well. Next, thanks, Jim. So, David, you might want to talk a little bit about the attachment behavioural system.
Yeah, well, this was a notion that John Bowlby, the father of attachment theory, presented in his early work. He was very interested in. He was a psychoanalyst himself, so very steeped in that culture, that therapeutic culture, and the model and the methods. But he was always also became very interested in the field of ethology as well, the study of animal behavior, and he had particular interest in the notion of imprinting, the work of Konrad Lorenz. Um, he developed, or he from this interest, he began to explore within the human realm the tendency, the innate, evolutionarily established tendency for young children to orient toward caregivers and to try to enhance and maintain connection with caregivers. Now, of course, the evolutionary purpose of this was survival, fundamentally. If an infant is closely in connection with a caregiver who is reasonably available to be in connection and to care for that infant,
Because humans are so vulnerable in their infancy, aren't they? Unlike any other species, really, the requirement for that proximity is so profound.
Yes, yes. So the behaviors that contribute to or that come from the attachment behavioral system are any behaviors that support the orientation toward the caregiver and maintaining the caregiver's attention. So you see here on this slide, proximity seeking, and because an infant's not able to, until about 8 months or so, the infant's not able to take himself or herself to the caregiver, it's really essential that the infant be able to capture the attention of the caregiver, to get the caregiver to come to him or her. So smiling is something that tends to capture the attention of the caregiver in a positive felt sense, making the caregiver want to go to the infant. Crying is something that also captures the attention of the caregiver, but is a little more noxious and would lead the caregiver to go toward the infant, maybe to try to help to stop that noxious stimulus, recognizing that the infant is in distress, and the crying tends to create some distress in the caregiver as well. So these are the fundamental elements of the operation of the attachment behavioral system.
Next. So as David's saying, this really important quality of attachment, it's really, really a significant part of human beings because for the first few years of our life, we are completely dependent upon adults to create conditions for our survival. Like if you think about a horse being born, they're up and running with the herd within hours. Human beings, they're really dependent on their parents for the first 30 years of their life. That's a joke. But certainly the first 6 or 7 years of their life, it's very, very hard for infant humans to survive in the wild. So this proximity creates certain conditions. And when these conditions are optimized, we create quality of secure attachment. Secure attachment is fundamentally important for the optimization of development. With secure attachment, we have more likelihood that we're going to, any of us are going to reach our optimal potential in this lifetime. So the conditions of secure attachment are, as stated here. And maybe you might want to address this, Traill, the 5 conditions.
Well, yeah, I mean, I think it's important to kind of set up that evolutionary kind of context to these conditions. Of course, one of the things that's very striking about these developmentally required experiences for stabilization of attachment are how closely correlated they are for what we need in therapy. That good therapists initiate the experience of being safe. They allow the person to be seen. They support comfort and soothing. They allow that person to experience their own value intrinsically. And of course, a supporting exploration and exploring the best self. And so it's really telling, I think, how closely correlated these early conditions for secure attachment are to the experiences that therapists are seeking to stimulate in their patients often. And I don't think it's an accident for that. Of course, 80% of psychiatric patients have attachment disturbance of some form or another, and it's such an essential kind of feature of our development, but also of our mental health and how we develop as human beings is so contingent in this early period. It's not to say it's an exclusive explanation. There are other dimensions, of course, but it is just so primary and so important. So that's always the thing that strikes me about these 5 conditions.
Yeah, let me add something to that. Thanks, Traill. One of the features of this particular way of presenting our understanding of what contributes to attachment security, both during infancy into childhood, through the developmental relational experiences, and also in the therapeutic context, is that this is considered a dyadic process. Okay? It's very much a relational process. The field of attachment psychology had largely focused on what behaviors are important from the parent or the caregivers to promote attachment security. But it didn't adequately recognize that regardless of how the parents may be behaving, what's really essential is how the infant experiences the behaving of the caregiver. Patricia Crittenden, one of Mary Ainsworth's graduate students, really highlighted this principle that a parent can provide all the right things from one perspective, but if the infant doesn't experience certain internal conditions consistently, then the attachment security will not develop. And so a parent may think that he or she is being protective, but if the infant isn't feeling safe with the parent, then something's missing, and that will tend to impede the development of security. So this is where the second condition here becomes really important: the caregiver's accurate attunement to the infant's experience and behavior and developmental needs at any particular time. So with that more accurate attunement, then the child is more likely to have the inner experiences that will tend to promote attachment security.
And that then becomes the 3 pillars, does it not? It becomes then, in therapy, creating these conditions, these 5 conditions of secure attachment through a collaborative relationship, building on metacognitive awareness, which enhances the development of the five conditions, which improves the capacity for collaboration, which improves the metacognitive view, which improves the underlying conditions. So it is a complete approach to attachment there. Using the felt safety and protection, feeling seen and known, which is attunement, felt comfort, soothing, reassurance, feeling valued, expressed delight. Wow, it's amazing. And felt support for best self, encouragement for exploration and discovery, capacity to kind of feel like you're engaged in a world that's really interesting and engaging. And this, of course, these conditions are what are absent in many of clients that we work with. So an accurate assessment of their status, their attachment status, is a significant part of the work in order to build then therapeutic intervention, which is ideally attuned to the needs of the individual, supported by collaboration and metacognition. Thanks. Next. As part of the assessment of attachment styles, David made mention of Mary Ainsworth and Patricia Crittenden, one of the main figures in the attachment universe was Mary Main, who developed an assessment tool for scoring adult attachment. This is a very detailed tool with a fairly strenuous training process based on a structured interview, which runs from between 45 and 90 minutes. That structured interview is then scored across several domains, and it then creates very specific categories. So you note here on the slide that the D is for dismissing or avoidant attachment. The difference between language for adult attachment and child attachment is still a bit confusing in the area. So we use for adults, we use dismissing, preoccupied, and secure. For children, or the languaging is anxious and anxious avoidant. Here we see that there are three categories of a dismissing attachment style: DS1, 2, and 3. There are 5 categories of a secure attachment style, F1 through 5. And what that means is that adults can present with some aspects of either dismissing or preoccupied attachment without actually being insecurely attached. They just have a kind of a flavour or orientation, but their core sense of self is nonetheless secure. There you have F3 in the middle, the prototypical secure, which really exemplifies those 5 conditions of secure attachment as manifested in adult. Then we've got 3 categories of preoccupied attachment, B1, 2, and 3. One way I think about it is, a child that's born distressed and hyper-aroused, that doesn't get relief from the hyper-arousal, remains in the E, in the preoccupied range. The child that is able to activate down-regulatory impulse, so cortisol response, flattens, becomes sometimes dissociated and becomes the dismissing. That's the kind of way I tend to think about it. And then we get this kind of more regulated individual in the middle sections. And I guess, from clinical experience and some of the research over the last 15 or 20 years in this model, what we can recognize is when these insecure attachments are identified in adults, we can target treatment to correct and bring everyone into status of secure. Well, not everyone, it's not a miracle cure, but when the treatment does work for people, that's the outcome. We correct these attachment disturbances and bring people into a secure attached status. And there's been a number of outcome studies underway where the AAI is run pre and post treatment to demonstrate that. Yeah, next please.
Yeah, let me comment on this. This highlights that I used the phrase earlier, but parents doing all the right things, and this gets to the very important issue of instrumental caregiving versus true relational caregiving. A parent may provide meals for the child, may provide adequate clothing, read bedtime stories, but there are all of those proper behaviors and beneficial behaviors can be done with an attuned presence, or it can be done in an instrumental way, just to do it to get it done. And doing all the right things is better than not doing the right things. But ideally, the right things, the right parental behaviors are done in the relational, attuned context. So this image here highlights instrumental caregiving. The mother is present with the child, or the mother is with the child. They're doing a shared task, but the mother is not attuned even to who the child is. So this is something that is really valuable for us to remember in working with parents, and also just in our own therapeutic presence with clients or patients. We want to make sure really present and attuned to who that person is.
Thanks, David. Yeah, Dan Brown, I know, would often comment on the excruciating pain of a child experiencing a parent who's present but not present. Little Amy here is really where she's at developmentally. Her brain is really needing the attunement of mum to really develop, and the lack of attuned presence whilst the mother is physically present, Dan would describe that as an excruciating pain. And it's an interesting feature of our generation, the degree of children who are not attended to in a very focused way by parents, but are distracted by electronic equipment, and spending a lot of time in childcare and that kind of thing. It's sort of all of these things have interesting consequences culturally. Anything you'd like to say about that image, Traill?
No, it's well covered.
Another thing Dan used to point out is the importance of parents to be able to engage at least a reasonable amount of time with the joy of parenting, not just the job of parenting.
Yeah. And in a very busy adult life, sometimes it's hard to find that joy.
That's why it's not required 100% of the time.
Yeah.
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 To a good enough degree is what's most important. Yeah.
It's such an important thing, isn't it, to be able to to change those developmental features in adults so that they can then learn to savor that quality of time with children. As soon as adults start to experience their attachment system, they start to recognize its presence far more acutely in their children, and are more likely then to attune to the needs of children.
Yeah.
It's a powerful intergenerational tool that we're working with here.
Had some very very moving experiences with patients who, I think of one in particular who as a parent was working in this approach to address her own attachment insecurity as an adult. And at one point, as we were going forward with this, she came in and said, I think since we've been doing this work, I'm loving my children more.
Yeah, beautiful. And next. So David touched on traditional therapeutic approaches to adult attachment. earlier a little, or the absence of focused approaches. There are a few now that have appeared. I know. I don't know if you were present, David, when Dan did the process with Diana Fosher, working with the same client. But Diana Fosher's work is more traditionally psychodynamic, where the therapist becomes the attachment figure in the therapeutic dyad, and so the process is more about working through transference and countertransferential kind of issues, working through defenses. Um, Otherwise, there's not a lot of other treatments for attachment disturbance in adults. Is there anything there, David, you want to say or try?
Well, just to highlight from what you said, the fundamental therapeutic model that was first laid down by John Bowlby is what we refer to as the therapist as good attachment figure,
Yeah.
TAGAF. And the principle is by providing the patient or the client with new and different positive relational experiences in the therapy process, that would get internalized and transform insecure internal working models, internal experiences of attachment history to secure models. There was also a component from Bowlby's approach that involved changing how the patient would think about his or her attachment experiences. So there was a cognitive approach
Mhm.
that would be included there. So even early on in this work, Bowlby was talking about the importance of a top-down approach where you'd reconceptualize your attachment experiences. Um, and also a bottom up, which is to provide new and different direct experience in the
Yeah.
therapy process. So different
Yeah.
therapy approaches have tended to emphasize one or the other of these top down or bottom up approaches.
You were going to say something, Traill?
Yeah.
Yeah, I just think it's really important that whilst that initial approach was certainly the dominant way of trying to resolve attachment disruptions within psychodynamic and analytic approaches, it just becomes inherently difficult. The process of the transference is so complicated when the attachment system is destabilized. So you're trying to repair the thing by stimulating the thing, and it often created a lot of problems, which I think is part of the brilliance actually of this model, where whilst there is a dimension of that kind of holding of course from the therapist, the focus is generating the stable attachment relationship kind of internally. And I think that that's really important to kind of flag for people just how complex and difficult the transferential treatment for attachment can be, and how this model actually gives you some really incredible tools for bypassing a lot of those difficulties.
Thanks. And Jen has asked, how is this model different? So perhaps the next slide. So with this model of practice, as Traill says, it's not a therapist to client relational model. What we're doing instead is creating internal resources within the client by drawing on the imaginal system, by drawing on the symbolic organizational quality of the mind. We're creating felt experiences with an imagined father and an imagined mother. We're doing it by not suggesting at any level that we're creating false memories. We're very, very clear that this is an imaginal process rather than some kind of memory reconfiguration. And we're encouraging, after having assessed someone's attachment status, we're then looking at what's required in this imaginal domain to create experiences that result in a felt experience, a visceral experience, an emotional experience of the 5 conditions of secure attachment. So this is a creative process that occurs between therapist and client. But it's probably the biggest leap in this work as a therapist to let go of the relational frame between therapist and client and actually trust that the client is able to find ways to create their own internal experience. We're at one level, we're coaching that experience as it emerges, but we're not doing it through the agency of our relationship. We're doing it through an imaginal process, a symbolic process that we're helping the client to work with and develop and to learn how to utilize. And as we do this over and over, what we've found over a long period of time now is that it creates these conditions within the client. Would you like to say a little more about that, David?
Yeah. So what, just to highlight an important element of this is that um, the Bowlby model, the therapist as good attachment figure approach, relied exclusively on the therapeutic relationship to transform the internal working models toward earned security. What we have found and consider to be a limitation of that approach is that the therapeutic relationship we know is very, very important for any therapeutic progress in any particular therapeutic model. But if we rely on the therapeutic relationship to transform a problematic or insecure internal working model of early attachment experience, we're not likely, but that's not likely to happen because as positive as the therapeutic relationship can be as experienced by a patient, the internalization of that will be an internalization of the adult self in relation to an adult therapist. So that can be a very beneficial internalization, but it will sit alongside the continuation of the representation of the early experience of self as child with adult caregiver. Okay, so we support the value of the therapeutic relationship. That's the first pillar. That's establishing a collaborative, dynamic, interactive, mutually contributory relationship between the therapist and the patient. That's fundamental. And in that context, as Nigel was saying, we as therapists help the client we as the therapist and the client co-create the imagery of the self as child having powerful, deep, security enhancing experiences with imagined parent figures. So it's the self as child in relation to imagined parents, not the therapist, but imagined parent figures that then gets internalized and actually can replace the early insecure representations of self as child with an adult parent, an adult caregiver. So relational dynamic experience with the therapist is important, but it's not the primary agent of change for the transformation of the internal working models of attachment experience.
So the next.
So through the imaginative experience of the self as child with new and different caregivers, it's never too late to have a happy childhood. Direct, bodily, felt, physical experience, visceral, emotional, affective experience of self as child with caregivers who are providing for the 5 conditions that promote security.
That's one of the kind of big takeaways from this, isn't it, Traill and David? That this is a hopeful therapy because it's creating something that hadn't been created. It's not a therapy about down-regulating symptoms or suppressing symptoms. It really is a transformative opportunity here to create something quite different and quite free of what is often intergenerational trauma. Next, please. So just briefly, the program itself. So what we've put together is a structured and supportive program to teach people how to work in this model. And we really want to work to build and support people's confidence in the model and capacity and skill in the model. And at the moment, we have a series of different trainings. We do a kind of an in-person introduction, and that's really a kind of just a very basic introduction to the program, which is a 2-day in-person training. This then leads into a very extensive and comprehensive level 1 online training. It's about 100 hours of training for people who really want to understand the basis of attachment theory, the research underlying attachment theory, different therapeutic models in attachment theory, and then it then focuses on our model of integrative attachment therapy. It has video demonstrations, assessment demonstrations, other videos, didactic videos, supportive videos, and reading and assessment throughout. So it's a self-paced program, but we do offer monthly community calls that we try to time for people in different time zones. So sometimes we're up bright and early in the morning, and sometimes we're a bit later at night, like we are now for some of us. And this is the training that's coming up in Melbourne in October that David will be flying in for, which is the level 2 in person. Now, this is a 3-day training, and in this training, we really demonstrate treatment of dismissing attachment, preoccupied attachment, and then the third, disorganized attachment. Disorganized attachment is usually related to severely inconsistent parenting in infancy, or to omission, so neglect or abuse in childhood. And this is one that is very strongly correlated with a number of mental health conditions. So we go through each of these aspects. We provide demonstrations and then opportunity to practice. So it's an experiential and informational training, level 2. And then level 3, which we will have again in Melbourne early in the new year. Level 3 is where people come in, bring some of their casework in the form of transcripts or recordings. And we really want to tie out that experience. Throughout the process, we also offer group supervision, individual supervision. And if you're really wanting to, join us on the path to becoming an IAT therapist, then we ask that people do 5 group supervision sessions, 2 individual supervision sessions, along with the level 1, 2, and 3 training in order to qualify as an IAT therapist. People are more than welcome to do parts of this training. But as I said, if you really want to learn the model and learn it well, this is the function. Ashley's asked, does level 1 give enough to clinicians to start working with clients, or is it purely theoretical as a grounding? Thanks for the question, Ashley. Level 1 is experientially oriented, so it teaches people how to assess attachment style and starts to talk about the treatment. But we wouldn't suggest that you are qualified to work in the model without additional training and supervision after the level 1. Any comments, David or Traill, on that?
Yeah, I think there's enough in level 1 for people to begin experimenting, bringing in some of the principles and the practices into their clinical work. But in order to, fully and most effectively practice the model, we recommend the full sequence of training. But certainly, with the information in level one, the demonstration videos in level one, the discussion of some of the challenges that arise during the application of this method, this set of methods, I think people find that they are able to at least begin bringing in elements of the work to try different aspects out in their clinical practices. Then, of course, when they come to level two, then there's much more opportunity for direct practice and focus on therapeutic challenges and problems that arise.
So level one is a significant training. Jennifer's asked, is there any training closer to Canada? We'll be in the United States next year, Jennifer, and in person. So we'll let you know of dates as they come, and we're certainly interested in training in the UK. We'll be in Germany in March of next year, so not too far away. Next, please. So this is the in-person training coming up. Said Traill, David and I will be involved in running that training on the 24th to the 26th of October. People who've done the level one are welcome. People who are already in the process of level one are welcome to come along. And because of the unique opportunity of David coming along, people who have background in attachment work may be eligible if you reach out to us, and we can have a conversation about that. And for people from this this webinar, we offer a thank you discount for attending the level two. You can get those details by scanning the QR code and getting in touch with our office. Thank you. So you can get in touch with us through the Integrative Attachment Therapy Institute online. You can also get in touch with us through support at integrativeattachmenttherapy.com. So thanks everyone for coming along and listening tonight. We've now got some time for questions. So we might shut down the slides. And if people want to ask questions in person, or if you're a bit shy, you can type them into the chat.
The thing that comes to mind is that many people who have background already in psychotherapy for adult attachment insecurity, when a number of people who have enrolled in the level one course said, well, I was expecting that this would just be a review of the field and a review of things I already know, maybe to deepen that. We hear so often from people that they're wonderfully surprised that in addition to getting a review, they're offered a different perspective on what they've already known. So it's not just review of methods and theoretical components, but the IAT training provides a new way of understanding and looking at what's been in the field for a very long time, and we're very very happy to hear comments like that, because that is the way that we hold all of this.
Been quite a consistent feedback that we've received. Dash, you've got your hand up there. You want to unmute yourself?
Yeah, can you hear me okay?
Yeah.
Nice. I'm wondering how you guys frame or think about the ideal parent figures protocol as being something which one would hope in like a couple generations from now that we might not really need something like this. Like, I'm wondering if you think about this as something that is, I mean, it's incredible, and I love this process. And I wonder if you see it as some kind of bridge that, you know, ideally this is something that parents in the real world are doing. There's a real experiences that we have that we don't need to use the imaginal system to
Of course.
jumpstart
Yeah,
the system. Like, it's amazing, but do you see it as temporary bridge?
Yeah, I mean, of course, Dash. I mean, our, you might have seen our catch cry there is towards a more securely attached world. And that, of course, is the ambition of all therapy, is to make it self-redundant. However, and I think it's a large however, um, the shape and the state of the world, I think means that it's not going to be a tomorrow thing. It requires an intergenerational approach. And whilst we know that intersecting at this early development would be, the best way of improving overall mental health, it's not something that kind of happens very much. And so this is an interim step, but we have to be realistic about that. It's going to take time. It's going to take generations of work. It's not going to just happen tomorrow.
The goal of our institute, and the reason we've set up the institute, is to make ourselves redundant as quickly as we can. We would like to see a world where this is no longer necessary. As your question of posits, Dash, it is for the first time we in human history we have the knowledge. We have the knowledge of what shapes a brain, what shapes a mind, what shapes relationship. It wasn't available when Bowlby started researching, and so the knowledge that we have now it's important knowledge that this is a correctable. Intergenerational trauma is correctable, and with the right function and the right focus on enough people working in this area, we can have a profound impact. Just having a look at a couple of questions here in the chat.
Was there a question there from Luke? Luke, did you pop in to make a question just before?
Yeah, I did. I was just thinking about with the 80% in psychiatric settings that were successful with this treatment, with the 20% that weren't. What was found that was might have been needed before in terms of treatment with those cases before they could do something like the ideal parental protocol. I don't know if I misheard that, but
I think that was your comment, David. Something about percentages, was it, or Traill?
No, I think what you're thinking about, Luke, is that 80% of psychiatric disorders attachment disturbance, right?
Okay.
As a backdrop, yeah.
Borderline personality disorder maps 100% onto disorganized attachment. So, it seems to be expressive of something very, very primitive and primary. But we haven't done large scale studies in psychiatric care yet.
Yeah, and a very important, and I think we find exciting element of the understanding of all of this is that because attachment insecurity underlies so many other problematic mental health conditions, often people who come to therapy for something that they don't recognize as attachment issues will really benefit from doing that focused attachment repair work before even addressing what they came to therapy for.
Yeah.
Resolve the underlying problematic foundation, then even without addressing directly some of those other issues will diminish.
Well, David, that's such a good point, just generally across the board. I mean, I think we can all speak to this generally, though, or more specifically, I should say, with treatment of trauma. I mean, it's extraordinary how just stabilizing this attachment process as part of the phase 1 of trauma treatment can essentially, metabolize a whole bunch of index traumas. So, it can be quite incredible how much of what the person was holding as traumatic is kind of alleviated through stabilizing attachment because they get the capacity to regulate the experience. They experience safety and trust in their body. They've got all these other kind of resources and components to manage what was an unexperienceable experience. It's quite extraordinary.
Yeah. Just for note for people in Europe, the German training will be levels 2 and 3 on the 11th to the 15th of March, 2026. So people are interested, and we'll send out some information to you if you're registered for information through tonight's webinar. Do you find that there are certain things, symptoms that preclude the client from connecting with IPF? For instance, hard to do the visualization. Not really, Jennifer. People to do this kind of work, people need to have some degree of stable reflective functioning. So people with, kind of psychotic disorders, manic disorders may not be suitable depending on circumstance. But for people who can't visualize very clearly, and there's a reasonable percentage of the population that have this issue. It's not necessary to visualize. What we can do is create a kind of quality of felt sense of proximity. So sometimes people can partially visualize, they get a sense of, or cloudy figures. Other times they just feel the proximity. And we find that you can generate these felt senses of secure attachment without necessarily having vivid imagery as part of the process.
Yeah, we just add to that, Nigel. We highlight that this is a process of imagination, not necessarily visualization, because the visual domain is one of the senses, one of the sensory possibilities. But when we imagine, we can engage any and all of the imaginative domains, and very much, as Nigel said, the felt sense, which really is the most important aspect of this process, to come to feel safe and comfortable in the body in relation to imagined caregivers, however they're experienced in imagination.
Yeah. If I can add to that as well, I mean, just an important piece is that difficulty when we're doing this work has the same value as transference might have in an analytic frame, that the difficulty is valuable. The experience of difficulty when we're stimulating the attachment system is in fact telling, and it's in no way a reason to desist doing the work. It's actually an indicator that the work is needed, and it helps us to develop a kind of sensitivity to what they're actually asking for and needed. I think that's very important to say there.
I often say to clients when they say, I'm having a hard time with this. This is too hard. I'll say, if this was easy, we might not need to be doing it.
Yeah, exactly.
Thank you. I'm just conscious of time. Chris, thanks very much for pointing to the section in the book about problems with visualization. We also do directly address this in the online level 1 training, and we are in the process of looking at providing an updated treatment manual as well for the work. Thank you very much, Maud, for your input there. The level 1 is rich and structured indeed. So thank you for your comment there. And yeah, please.
I just want to say that I really understand that all models are so different, and that's the point, that things have been lacking in other models, and that's how we get to this. I'm just trying to conceptualize it. And is there like a part in a way that's similar to an IFS approach of going in and updating younger parts that are stuck or trauma? That's how I'm trying to think of. I'm trying to picture how this model works, and that's what.
Thanks, Jenna. There's plenty of examples in the training, but essentially what we're doing is we're inviting the client to close their eyes, take a few deep breaths. We've already done a lot of assessment, a lot of setting the frame, but when we're actually in the treatment itself, we're inviting the client to relax, take a few deep breaths, come into their body, and then imagine themselves or get a sense of themselves as a 5-year-old or somewhere between 5 and 12 in an environment that isn't part of the memory system, that's in a park or in a garden or on the beach. And then we invite them to imagine two ideal parents, mother and a father, there and present with them. And so the therapeutic session begins with collaboration, setting up the container. In the sort of middle part of the session, there's this imagery work, imaginal work around the parents and the felt sense. And then the last phase of the therapeutic session is mentalizing, making sense of, coming to terms with, comparing what they experience with what they experience in imagery. And there's a kind of a structural kind of working. So at one level, we are at some sense working with a type of IFS symbolic register. So IFS is working with symbols. We're using it specifically about the developmental attachment needs. So the imagery is really the ideal parents. Sometimes we get memory intrusions, so the real parents turn up and the ideal parents need to ask them to leave. And so it can get quite nuanced in the way that it works. But essentially, we're building a kind of an imaginal frame. I hope that answers your question. Ashley asked about an average span of treatment. Depends. I think the full treatment can run for a couple of years in some severe cases, David, but can be significantly shorter than that. Depends on the presenting problem and the.
Somebody with a disorganized attachment pattern of insecurity and a trauma history will take longer. Any therapeutic process would take longer, but we find that it takes less long if we address the attachment issues in the ways that we're describing.
Yeah. So thanks, everyone. Jennifer, I think that's just a statement about ADHD rather than a question. So I might just leave that unless there is a question. And so working with a therapist is an important aspect.
I guess what I was trying to say is my concentration, like I go into, like I've been doing it for over a year, this model, like as a client, because anything I practice as a clinician, I do as a client too. And sometimes I find I can't, like it's hard because of my attention to stay with it for very long. Like I can stay with it for about 10 minutes and then it's like, okay, I don't have anything more to vision. Like, do you know, I don't know if that makes sense, but.
Yeah, I mean, people will have different experiences. So sometimes imagery work is that short. Sometimes it might go for 30 or 40 minutes, particularly as people are getting more used to the structure. But that's probably more kind of, there's a lot of detail in the question there, Jennifer. And feel free to reach out if you want to be more detail about treatment.
Thanks. I mean, I'm looking at level 2 and 3 in Germany. I'm almost I'm sort of more than halfway through level 1, but okay.
A lot can happen in 10 minutes of the imagery process. So don't undervalue what you're experiencing.
We'll see. Sometimes it just feels frustrating because after a while I'm just like, no, I can't think of anything else. Like I'm done, kind of thing.
And that's when you learn to trust your intuition, instincts, and then you're cooked. You're cooked for the session. And so as David says, a lot can happen in 10 minutes. We've got a little bit over time, guys. So just really going to thank you for really, really fascinating questions and the engaged audience. And we really look forward to meeting with some of you along the track, whether you can make Melbourne next month or one of our other offerings in Europe or America or online. We do offer online seminars and other components of the training. So yeah, it's been a pleasure having you along, and we hopefully will see you again.